Hello everyone, my name is Ziad Afas and today I'm presenting a case about co-disposition of AL and ATTR amyloid proteins in the heart, a rare finding and a therapeutic dilemma. Introduction: cardiac amyloid is being recognized increasingly in the clinical practice due to advances in diagnostic tools and availability of newer therapeutic options. Two amyloidogenic proteins are responsible for the vast majority of the cases, AL and ATTR, while the latter can be diagnosed non-invasively with a PYP scan after ruling out monoclonal gammopathies. The presence of abnormal monoclonal proteins will require a tissue biopsy then. Biopsy staining with Congo red confirms the presence of amyloid protein. However, it does not distinguish the type, and additional testing with mass spectrometry is required. We present a rare case of biopsy-proving co-disposition of both AL and ATTR proteins in the heart. Our case is a 67 years old African American man with a history of hypertension, carpal tunnel syndrome, smoldering myeloma, presented with dyspnea and lower extremity edema of few months in duration, but worsened in the prior month. Workup showed bilateral pulmonary emboli and severely reduced ejection fraction because of his smoldering myeloma history. Workup to rule out cardiac infiltration was recommended. Cardiac MRI was inconclusive, thus a biopsy was done and showed amyloid protein infiltration. Mass spectrometry was then performed for amyloid typing, and the co-disposition of both AL and ATTR protein types were confirmed. Discussion: cardiac amyloidosis typically present with heart failure with a preserved ejection fraction picture. The two major types, AL and ATTR, are clinically indistinguishable. Once suspected, screening for abnormal monoclonal protein should be done as a first step, as their presence will require a tissue biopsy, while patients could still have monoclonal gammopathy of unknown significance, AMGAS, and have ATTR cardiac amyloid doses on biopsy. Have both protein types infiltrating the heart is very rare. On one report, only 9 out of more than 1,000 biopsies showed this rare finding. Our patient presented with severe heart failure and bilateral pulmonary emboli. He had severely reduced ejection fraction, which is not typical for cardiac amyloidosis patients. This case presents clinical dilemma, as it's difficult to ascertain which type is responsible for his presentation. In conclusion, co-disposition of AL and ATTR protein in the heart is rare, with wide use of non-invasive testing to diagnose cardiac amyloid. Rare cases like ours highlight the importance of tissue biopsy and the need to develop tests to quantify amyloidogenic types when more than one type is present. Thank you.